It is now my pleasure to turn this call over to ASTHO CEO, Dr. Michael Frazier. Mike, please go ahead.
Thanks so much, Rena, and hello, everybody. Welcome to today's webinar, COVID-19, a conversation on data, communication, and health equity. And on behalf of the Association of State and Territorial Health Officials, or ASTHO, and the National Public Health Information Coalition, we'd like to thank you for joining us for our time this afternoon. I'm Mike Frazier, and I'll be moderating a terrific panel of experts. Today's webinar will feature a discussion about COVID-19 and the fight against misinformation and health disparities. Our panel of leading experts will explore the role that data can play in elevating public messaging, as well as offer insights into how to take a data-first approach to tell a story that resonates with diverse audiences. This is actually a second installment of a series called Ask the Experts, Crisis Communication and COVID-19, which is a expert-led series from ASTHO on developing clear, urgent messaging and communication around COVID-19 response. And as mentioned, it's a joint effort of ASTHO and NIFIC, supported by the U.S. Centers for Disease Control and Prevention. And I just want to take a minute to introduce you to our speakers. We'll hear from Dr. Wayne Frederick, who's president of Howard University in Washington, D.C. Dr. Frederick previously served as Howard's provost and chief academic officer. And most recently, the Howard University Board of Trustees selected Dr. Frederick to serve as the Distinguished Charles R. Drew Professor of Surgery. He was named Washingtonian of the Year by Washingtonian Magazine in 2015. Second, I'd like to introduce you to Dr. LaQuandra Nesbitt, who's our district health official. She's a board certified family physician with over a decade of experience leading population health initiatives. Dr. Nesbitt currently serves as the director of the District of Columbia Department of Health in Washington, D.C., a position she's held since January 2015. And I can tell you, we all appreciate the work of Dr. Nesbitt and her team as organization with our headquarters in the nation's capital. We certainly thank Dr. Nesbitt for everything she does, as well as our health officials in Virginia and Maryland. As a physician leader, Dr. Nesbitt mobilizes organizations and communities to implement innovative solutions that promote health and wellness and achieve health equity. And finally, I want to introduce you to Dr. Jillian Steele-Fisher. She's a senior research scientist and director of global polling for the Harvard Opinion Research Program. Dr. Steele-Fisher received her PhD in health policy from Harvard University, and she currently serves as president emeritus for the New England chapter of the American Association of Public Opinion Research and as a thought leader for the National Public Health Information Coalition. We're actually going to start with Dr. Steele-Fisher and her presentation. So now it's my pleasure to turn the microphone and the Zoom over to Jillian. Thanks for joining us. We just want to make sure you're off mute, Jillian.
Sorry, it wouldn't come off mute while I was in putting the slides up, but now that I have them up, I can talk as well. So thank you all so much for joining today. It is so great to see you as part of this important conversation that we're going to be having. As everyone who's come here today, I'm sure would say, the issue of health equity has been manifest in this pandemic in so many different ways, visibly and invisibly, ways that we have yet to untangle. And there are a lot of different sources of data that we can use to help call out these inequities, to understand them, and to ultimately address them. So in the introduction, it was noted that I'm the director of public opinion research at the Harvard program. So not surprisingly, I'm going to be sharing with you some public opinion data. And I'm actually just going to be using it to open up the dialogue. I'm not going to give so many answers today, but really to kind of unearth and show how the data can give voice to some of these critical issues. Now, the reason that I choose public opinion data, not only for this presentation, but also more broadly in my career, is that I think public opinion data, even though it's often used really to sell newspapers, it's poll headlines, it has this very important element in our policy and democratic process. in terms of being a voice for people, a way to bring people's voices to the table. And so with that lens, I want to show a little bit of data that can help us unpack some important issues around the issue of equity and vaccination. So hopefully this will just bring some themes that colleagues will then begin to discuss more fully. So let's start kind of with the issue, this most fundamental, which is the issue of vaccine uptake. Now, many of you will not be surprised to see this data as you've seen similar data in other places. Really, it shows that Black and Hispanic adults are less likely to take up vaccination initially. So when the question is asked, if the coronavirus vaccine becomes available to you at no cost, would you get one as soon as possible? Consider one, but wait to see what would happen to others, or never get one. And what you can see is that in this top category, get one as soon as possible, only 24% of Black adults said that agreed with that statement, whereas 42% of white adults said the same, and 30% of Hispanics said the same. So the issue here is that from a public health perspective, of course, we know that communities of color have been more likely to suffer the consequences of COVID-19 disproportionately. And yet, we'd love to then see, okay, more support going to these communities to ensure that they're served equitably. And yet when we see this hesitation, this is an additional challenge. Now, what the data bring up is sort of just, this kind of says, okay, well, people are hesitant. The immediate question, of course, is why? And so some of the data can really help us dig into that, because historically, some of this hesitation makes sense, right? We know that the biomedical enterprise, its history of structural and active racism, really poses a fundamental challenge to people's trust. People don't want to be a guinea pig. And so they are worried, and we can understand sort of where this comes from. How can we unpack it, though, particularly from the realm of communication? What can we say? What can we do? So when I think about trust, the data really would suggest there's two key dimensions of trust. One is trusting in the technical element of a vaccine. That is it safe? Is it technically correct? Is it going to have the appropriate immune response? And the second is thinking about whether or not the actors and agencies behind that have the people's best interest at heart. And what we can see is that both of these dimensions are really different among Black adults and Hispanic adults as compared to white adults. So the question that asks, how confident are you that when a coronavirus vaccine becomes available, it will have been properly tested for safety and effectiveness? Right from the beginning, we saw there was differences in the way Black adults and Hispanic adults compared to white adults had confidence in that system. Similarly, when we ask how much confidence, if any of you have in medical scientists to act in the best interest of the public, we see these same kind of disparities in perspective. And in more recent questions where we've talked about, how confident are you in the ways that the vaccine has been tested and rolling out, we see these are persistent. So there's a question asked among Black people, how confident are you, if at all, that the COVID-19 vaccines were adequately tested for safety and effectiveness, specifically among Black people? And we see is that only 16% are very confident. 16%. Among Hispanic adults, only 23%. So it really poses a huge challenge. Similarly, it's not just about the vaccine testing, we also see it in the distribution. So again, the sort of multiple dimensions. Among Black adults who asked, how confident are you, if at all, the distribution of the COVID-19 vaccine in the US is taking the needs of Black people into account? Only 15% are very confident. Similarly, among Hispanic adults, how confident are you? Only 24% say very confident. This really suggests the sort of fundamental level of concern that people have, that there's a challenge to us as communicators and as to public health leaders. Finally, you'll note that there's not only disparities sort of in perceived uptake, in trust, in multiple dimensions of the trust, and in perceptions of the development and rollout, but also in the information. So when we asked about whether or not people have enough information, the fraction of Black adults and Hispanic adults who say they do not have enough information, again, is greater than whites. And that's about when people will be able to get the vaccine and where you'll be able to get the vaccine. These are basic fundamental elements of the communication. So I think what I'm hoping these data bring to the fore is the challenges around equity are multiple, they are intersectorial and interrelated, and in addressing them, we need to take them on comprehensively. So let me sort of leave it there because this is the beginning of the conversation today, and turn it over to colleagues who are going to take us to the next level in the conversation.
Great. Thanks, Jillian. And now I'd like to turn over to our next presenter and remind folks that speakers will be answering questions at the end of all three presentations. So please feel free to put your questions in the chat, and we will be looking at those after all three presentations. Dr. Frederick, welcome. Thanks for being with us. We appreciate you. We've got several of your alumni on our ASTHO team, and they're awesome. So we're just thrilled to have you speak to them and to all of us. Thanks for joining us.
All right, thanks for having me. And I'm actually just going to speak. I think the data just presented says it all. I do want to thank the Association of State and Territorial Health Officials for this opportunity. Your work has been critical. It always has been, and I think it's even more critical today, to be quite honest. And I hope that at the end of the day, you do appreciate and feel appreciated by all of us who benefit from your work. During this pandemic, when every person needed information and guidance to keep themselves and their families safe, your efforts became even more vital to our individual and social welfare. You were put under the spotlight and beneath the microscope at times, but public health officials responded in the best way possible by continuing to do their jobs as they always had done before. Howard University's motto is excellence in truth and service. The work of public health officials encapsulate both of these values. You discover and promote the truth, and you use that to serve the public. That's what we tell students who come here to Howard. We tell them that they come here to get the truth in the classroom, but they don't come here to get a degree. They come to get an education. And that comes alive when they take that education and go out, that knowledge, and go out and serve the world around them. This COVID-19 pandemic has really stretched what is expected of all of us, but it has also, I think, underlined and emphasized what you do every day. In your line of work, truth is found in data. Amidst all of the partisanship and political gamesmanship in our country today, the work of objective public health officials who anchor their work in facts became even more essential. That data helps counter all kinds of misinformation. And so one of the things I hope you will continue to do is to make sure that you continue to push that data out. Regardless of what it says, that truth spoken by you is more critical than anything else. The data also identifies trends and reveals problems that might otherwise have gone overlooked. And so it's extremely important as we have social challenges that you put that data out. But what's just as important as the data is that the data needs a narrative. And that narrative should be supported by the data as well. So in public health, we cannot have one without the other. We need context to understand what data is telling us, and we need data to internalize the narratives that have the potential to change our behavior and our beliefs. And we have to recognize that everybody interacts with that data differently. Everybody comes to that data with a different set of perceptions. And so that's why it's extremely important that you give life to the data through your narratives. And that data that gives life to the narratives as well, that can change societies, is extremely important. This pandemic was a public health crisis of the kinds that we have not seen, demonstrating some of the inequities and injustices that I've spent my entire career working on. And Howard University has been on a caravan to social justice since its founding 154 years ago. Data has been one of the most critical ingredients in the fuel that powers the social justice caravan forward and propels it to a place where we can all feel comfortable we would have the right facts in order to make important decisions. And we need to be armed with the facts. Black Americans are twice as likely to die from COVID-19 as their white counterparts. And Black men, for instance, living in Ward 7 and 8, have a life expectancy that is probably 20 years less than white women in Ward 3. These are things that we must come together and make sure that we are fighting the good fight with data and with informing people of what must happen. The other thing that must happen is that we have to improve media literacy so people can better identify misinformation and know how to find trusted sources of information. And I know in these times, it's probably difficult to suggest that somebody should get closer to the media and engage with them, but I think it's a powerful tool. to arm folks who are going to have large platforms and big audiences, to arm them with the facts and to ensure that they can let people know what must be done. We've been blessed here in DC to have as our Department of Health head, Dr. Nesbitt, who you'll hear from soon. Her ability, along with the mayor, to provide the data and the facts consistently in a very clear and coherent manner has made a significant difference. It certainly made a significant difference on our campus. And I think it underscored that if we come together with those facts, we can certainly get through this. In times of uncertainty and confusion, it is vital that we lead with the facts and the honesty. So we've got to be upfront, and sometimes that's going to be difficult. HBCUs play an important role, and we've seen this during our vaccination process. We are a trusted messenger in this community. People expect to hear from us. They also expect that what we say is going to be valid. And so once we stood up our vaccination center, we were able to see, even with all the talk about vaccine hesitancy, a willingness for African Americans in particular to come and be vaccinated. The logistics issues that occur should not be the problem of health officials like yourself. But the reality is that our entire society does not get an opportunity to distinguish between these facts. The mistrust and the distrust that has occurred around the medical community is not unique. The Black communities in our country have been the subject to harm from a wide variety of governmental institutions. So whether it's law enforcement, the banking industry after the mortgage crisis, people then begin to distrust government in general. And as a result, our public health officials fall under that. That shouldn't be daunting. I see that as an opportunity. I see it as an opportunity for us to be more transparent and for us to tell the stories around issues that we think people already know about, because the fact is they don't. We hear a lot about the Tuskegee experiment, but the average American, if stopped, cannot tell you the details of the Tuskegee experiment. And I think what we've been trying to do is to start a narrative from today, go forward, rather than going back and really making sure people understand and therefore have something to compare and contrast against when we say to them that that cannot happen today. And I think we have to be willing to do that. And you as public health officials, I think, really should lead that in terms of how you bring that message. So while Howard has been a trusted and leading messenger, we certainly continue to look for opportunities to spread that. And we want to overcome vaccine hesitancy. We have to get people vaccinated, but more importantly, we're not trying to force people to get vaccinated. We're trying to educate them about why they should get vaccinated. And so I want to end by thanking you for all the work that you do. These are thankless jobs, there's no doubt about it. My mother was a nurse for 51 years and basically was a public health official for the latter part of her career. And I saw what she did. She has now come out of retirement to help with vaccinations in Trinidad and Tobago, which will start in a few weeks. And so I witnessed that work up front. It's work that you take home to your families. It's work that never leaves you. It's work that you can't get away from, because even at home, when you turn on the television, they're talking about a crisis that you're actively trying to fix. But I hope you would recognize that people like myself remain indebted to you. And while many of us will not get a chance to meet you, you clearly protect us, and we're very thankful for that work. So thanks again, and I look forward to the Q&A.
Thank you, Dr. Frederick. We really appreciate those remarks, and thanks for all you're doing in your campus and across the country with your students. I'd now like to introduce our next presenter, Dr. LaQuandra Nesbitt. Dr. Nesbitt, thanks so much for joining us. And again, thanks for all you're doing both in the district, but also nationally with your colleagues through ASTHO. We appreciate you.
Thank you, Mike. Good to be here. I'm going to go ahead and get started. I'm a visual learner and listener, so we've thrown together a few slides that I won't take very long to get through. On the next slide, you'll see that we start many of our discussions, not just with this group, but with our community in terms of anchoring people around the challenges related to supply and demand, much of which was put in our original plan for distributing the vaccine back in October before we even knew what vaccines were going to be approved and what their storage and handling requirements were, et cetera. And we have found that really when we're having community meetings or we're meeting with small providers who are eager to become vaccine distributors, being able to show them that we're still in that area of the red circle. And once they really appreciate the storage and handling requirements of the mRNA vaccines, many of them are positioned to wait until phase 2 or phase 3. We do have a gift for them that we have created here called a vaccination referral site program that would allow these providers to get a decal in their window, be able to answer questions related to COVID-19 that their clients, customers, or patients or parishioners may have, and being able to assist them with getting signed up for doses of vaccine until they are available in even more locations. On the next slide, you'll see that we have been trying to be as progressive as we can in terms of moving through the various phases. We now have dates when these individuals will become eligible, and a goal to ensure that everyone in a priority group has a few weeks of eligibility before we get to the May 1st requirement by the federal government to have everyone be eligible for the vaccine on May 1. Like many of you in many states and jurisdictions that are managing these programs, our limiting factor here is vaccine supply. So we get lots of demands for particular essential groups to be vaccinated, to be given priority for vaccination, et cetera. And it's been extremely challenging to communicate to those groups that with 24,000 doses of vaccine for an adult population of close to 600,000 and a workforce that comes into our city that doubles that number, has been a little challenging to move through the process. Next, I'll show for you how we have managed our vaccine distribution schema. When you look at the next slide, you'll see that ours is not different from what happens in the federal government. You can just load all those quickly. It's basically, we get notified of how much dose we can order. The Biden administration has done a much better job of letting us know that the number will never be lower than the previous week. And then we ship those, have those vaccines directly shipped to 3 different entities, or we call them buckets, vaccine and subsequently appointments that we invest in every week. About 60% of our doses go to our vaccinate.dc.gov centralized portal, where individuals sign up for a vaccine. We changed the process last week where people can pre-register, and then every Thursday and Sunday, we send out appointments for people to schedule. The next bucket, about 30% of our vaccines go to our hospitals and federally qualified health centers and community health centers. We have about 8 acute care and specialty hospitals that are vaccinating their staff, vaccinating their patients, any patient who has been in their system in the past 2 years. And all of our federally qualified health centers are engaged in receiving doses of vaccine and have been since the end of December. And then our third bucket are about 10% of doses that go to what we call special initiatives. And these special initiatives help to have more of a grassroots versus grass tops versus the government and healthcare institutions reaching out to individuals for vaccination, but really partnering with community-based organizations such as through our Faith in Vaccines program, using volunteers who go door knocking in our neighborhoods with the highest burden of COVID-19 related illness, and also partnering with a health system and the housing authority to offer vaccines on site in our public housing system. Next, you'll see that we have really been focused on efficiency, just like everyone else on the next slide, but we don't let efficiency get in the way of equity here. We administer on a weekly basis. This does not discount the data lag that we still have from some of our providers, but even with the data lag, we're moving 86% of doses or more on a weekly basis. Next, when we talk about the use of data from an equity perspective, again, I mentioned that all of our federally qualified health centers have been receiving a state allocation since the end of December. All of our hospitals and Kaiser, they were all recipients of doses of the vaccine in the very first week of the program. And then we have community-based partnerships and initiatives. This sort of 3-pronged approach allows us to think through when we receive doses on a weekly basis, where should we be placing those doses, right? So about 40% of doses go into this bucket. Now, the 60% that doesn't go into these buckets, that goes into our centralized portal, we set aside half of those doses for our neighborhoods and communities that have the highest burden of disease. So every week, of the 60% of the total vaccine we get, 50% of that goes directly into the neighborhoods with the highest burden of disease. When you take into consideration that the federally qualified health centers, this is their same patient population, and the community-based initiatives that we have that are in partnership with churches and housing, public housing, as well as aggressive door knocking campaigns, that increases even more the proportion of our doses every week that are dedicated to our communities with the highest burden of disease. Every hospital, acute care hospital and health system in DC has been to date providing the most doses that they give to the people in the immediate area in which their facility is located. And that may be a function of their patient service area, and it's also a function for our one hospital in Southeast DC where we've had the highest burden of disease. They've been overly committed, if one could be, to making sure that they are reaching out to the community and not just taking care of their patients. Next, I'll kind of show you really quickly how we really thought about the distribution of our vaccines. Again, our supply is very limited. And so we have a number of sites. And when you look at the next map, you will see and say, wow, there's sure a lot of places in the middle of the city. But what we articulate to people and what this map shows is there are gradients in terms of this map. And so in the middle of the city where you have so many of the blue stars, those are retail pharmacies that have a very low throughput on a daily basis, which compared to the green dots on the periphery, which are our large high capacity sites. So you really have to think about the throughput of each of these facilities and not just the location itself. Because we're only 68 square miles, it's very difficult, unlike other states, to assume that people don't move around the city to get an appointment. These locations, any location is convenient for most of our folks who have influence, affluence, and resources, whereas in some neighborhoods, most people do not leave their neighborhood for healthcare or health services such as vaccination. Next, you'll see sort of how, we can skip that one because I've talked about those initiatives already, but you'll see how this has kind of played itself out in terms of our data. Because our healthcare worker population was about 75% non-DC residents, and then we have other essential workers that we were onboarding, we have just around 60% of our doses of vaccine are actually going to DC residents. The other ones are going to non-DC residents who are essential workers. We have had to make some policy decisions recently to scale back the percentage of doses that go to our essential worker population. So just about 20% of our doses every week are going to that population, and we're starting to load more of our doses, 80%, into those DC residents' access. Next, you'll see our race and ethnicity data about now the district, the largest racial and ethnic group in the district are Black African Americans. They're about 48% of the population, followed by whites. Our Latinx population is about 10%. When you look at the distribution of who's been vaccinated in the district, about 27% of our doses of vaccine have gone to Black individuals, and about 30% have gone to those who identify as white. We, like many jurisdictions, did not have the best reporting from our healthcare providers in the first month or so of the program. We are using techniques such as matching with other data systems, vital records, the health information exchanges to clean up that data. And we continue to reduce the percentage for which there are people with an unknown race. From an ethnicity perspective, we have about half, or 54% of our data does not have a documented ethnicity. Of the cases that we do have, about 9% of them have identified as Latinx or Hispanic. Next, you'll see that we have a very huge focus. All of our data we publish in terms of where things are happening. On the bottom of the slide, or the bottom right, what we refer to often as Southeast DC, the East End, east of the river, our geopolitical construct or wards, so that would be wards 7 and 8 for us. You can see by the shaded gradient that the uptake of vaccine in that population has been lower. So this is actually a coverage map. This isn't just numbers of doses that have been given. And you can see that we have some places in Northwest DC where a much higher proportion of all of the people in that neighborhood, close to 20%, have been vaccinated, whereas we have other places, other neighborhoods where less than 1% has been vaccinated. Being able to look at this type of neighborhood data allows us to direct the energy and activities of our Senior Buddies program, where we're going to focus in terms of doing going out to housing communities. And it also allows us to really focus on prioritizing the number of community-based partners and faith-based organizations or places of worship who want to have sort of one-day pop-up mobile clinics. So looking at where we really need to increase coverage helps us to be able to make those decisions. So I'll stop there and say, like, most folks who are managing these programs, the 64 jurisdictions that are receiving direct doses, have to make a lot of decisions in terms of equity, in terms of prioritizing where doses go, how appointments are assigned is as important, if not more important, than the actual physical location of the testing site and clinic. And to that end, I think we have to be extremely mindful as more doses come into our jurisdictions as part of the federal allocation, that we remain aligned with those entities, the Federal Retail Pharmacy Partnership, the federally qualified health centers, to ensure that they share the same equity goals that are outlined in many of our vaccine plans. So I look forward to a Q&A. I'm very happy to be here with the other esteemed presenters. And as always, Mike, I know you'll take it very easy on us. Thank you.
I'll take it very easy, of course. I will ask all the questions we receive in the Q&A. If folks can use the Q&A button on Zoom, please type your question, hit submit. We've got several already. But before I ask the first question, I just wanted to remind folks, if you could take a few minutes to complete our webinar evaluation. That link will be available in the chat as well. So why don't I go ahead and, excuse me, and ask a couple questions that we've received. Here's a question, I think, for all of you, really. States are struggling with balancing equity and with the speed of getting shots in arms. How do we accomplish both simultaneously? And Dr. Nesbitt, you shared sort of your approach, which I think sounds great, but any more detail there or any more information to share?
Sure. On behalf of all of my health officer colleagues, and both at the ASTHO level and the cities that are managing these programs, I think the worst thing that happened to us was everyone thinking that the best metric for vaccine program efficiency was how quickly you're moving your doses. And so for all of our partners, the way we manage this is that you can request an allocation from us. We'll try to meet as best we can the allocation that you request from us on a weekly basis. But we also get to see what your administrations have looked like. If you're not submitting data to us, to our immunization registry, we've done a much better job now pairing what you enter into the vaccine ordering system and what you are actually submitting to us in terms of individual patient data. If you're not being efficient, then we don't continue to give you more doses. We put those doses in places where we know there is demand. And while there are lots of conversations about hesitancy, there was only a 2-week period before we brought on our 18 to 64-year-olds with qualifying medical conditions where we had a lower uptake than optimal from our seniors who live in our priority neighborhoods. Now they continue to enroll, but much of this is just a manifestation of the wait and see approach. So we've adopted the, you got to go slow to go fast approach. And we think of, which I've stolen that from one of my colleagues in ASTHO, but what that means for us is that the faster we can recover is by protecting the most vulnerable. And the most vulnerable isn't always by age and qualifying conditions. It's in those neighborhoods where we've had the most disease. So for us, going fast and getting to recovery and on the other side of this pandemic means that we may allocate 2 weeks ahead of time doses for a faith-based initiative. We may allocate thousands of doses into a housing program, knowing that it's going to take 3 weeks to move all of that vaccine. But that is important for us to do because you have to have concrete plans in place in order to execute. So those types of things are what has been helpful for us in balancing equity and efficiency.
Some balancing equity, efficiency, and the vaccine effort. All right, well, I'll turn it over. Dr. Frederick, I got a question for you. What are some ways that you are working on campus or with your colleagues to increase acceptance and reducing hesitancy in the African-American community?
Yeah, we've been doing a few things on campus. One is all of the leaders who took the vaccine initially did a PSA to try to get acceptance, to make sure that people saw us stepping up very early on and taking the vaccine. The other thing that we've done is we've set up these town halls as well as small group sessions to speak to everyone about the vaccine. And like I said, the key here is engagement and education, not trying to force anyone to do it. The conclusion is not that everybody has to get up and leave and go get the vaccine, but we want to make sure that people have the information to make the decision. And we think that that has proven to be a very strong approach. I've held myself out to the entire community, 5,000 employees and 10,000 students, that I'll speak to any one of them or their family members about the vaccine and any questions they may have. And some of them have taken me up on it, as you can imagine. And so we've made sure that the leaders of the organization have also made themselves available, because it's extremely important to have that happen. And one of the most, I think, convincing things that happened is that the head of my environmental services, he decided to get the vaccine. Prior to him getting the vaccine, I would say barely 10 to 20% of the custodial staff were interested in getting it. And now they are among the highest percentages of workers at the hospital who have been vaccinated. So we've really taken an approach of, trying to push information out there and let people be aware. The second thing that I would say has been critical is making sure that we also are trying to keep our messaging in line with the Department of Health here in DC. I think one of the things, especially for communities of color, is that in our eagerness sometimes to push information out, if we're giving different messages, that can actually become a point of confusion for those communities, and that can actually increase vaccine hesitancy, because people tend to hold on to, well, the health officials are saying this, the folks at Howard are saying that, and that can create a wedge. So we've tried to be very disciplined around that. So questions about the different types of vaccines, we try to make sure our messaging is consistent with what is coming from our public health officials as well.
Great, thank you, Dr. Frederick. Jillian, there was a question about research comparing rural and urban findings.
Can I also jump in on the other question though? Is that allowed?
Please do, yes.
Okay, so I was just going to bring up a data point as well, sort of building off colleagues' comments around how to connect with communities. And I wanted, for communicators out there, I want to think about what the data says about that. So in my opening sort of comments, I was trying to say that, engaging trust means you have to have two sides of people's heads. You have to have the side that says, hey, you've got the technical expertise that you've got something to say about this vaccine, and you care about me. You're not gonna treat me wrong. And those two sides coming together is what makes it compelling. And what the data shows is that overwhelmingly, people believe that physicians and their physicians embody those two parts. So when you're looking around for spokespeople, for places to connect, make sure you're including some physicians in that. I think that's sort of a kind of quick takeaway that people can say. It's true across lots of communities, and it's not that we don't want to include other folks who are important, who might have a particular resonance in a particular community. So that's not to say, but make sure you've got sort of bringing into the fold physicians, because people, that's a go-to resource for so many communities. And bringing them together as part of that communication, I think, can really connect on those two halves. And then thinking about for your particular community, who else does that? Who can you bring together? People that care about you, whether that's faith leader or others, and person has the technical side, how can that kind of come together? That's really the key in finding trusted messengers. Now you're going to ask me another question. So let me stop talking and let you ask that.
No, thanks. That was great. There was an interest in any comparison you have between rural and urban data.
So yeah, so it is true that when we look at the data around willingness to take the vaccine, we are seeing a difference that folks in rural communities are less likely than folks in urban communities to say they're going to be taking the vaccine. And I think that's a challenge that that we're going to see kind of increasingly over time, in the sense that right now, we have more demand than supply, and eventually we're going to have more supply than demand. When we get to that stage, then we're really going to talk about that next level. So for the moment, I think we're really focused on how can we distribute equitably the vaccine we have, and how can we use that process to foster long-term demand. So I think that some of the issues that colleagues have mentioned today really speak to that and how we can do that effectively. When we're talking about rural communities, there's less demand, there's less burden of disease in many cases as well. And so thinking about that, I see that as a little bit sort of next step. How do we do that? So looking ahead to the future, which is going to be here in a flash, I think the same principle of how we figure out who is most trusted in those communities. So how do we have, in communities where there's more conservative values politically and otherwise, how do we connect with those folks? And how do we bring in trusted messengers for them so that they can feel that they're getting both technical expertise and they feel that this person is not going to disserve them? I think many folks feel that the vaccination issue has been politicized. And so trying to undo that is our challenge. And that's going to come up on us pretty quick.
Great, thank you. This question is for both Dr. Nesbitt and Dr. Frederick. We're in the
I think we lost you, Michael.
The question was, how do you stay connected with the health department, Dr. Frederick? What does that communication look like? And then there was a question to follow up. Did the DC Department of Health do any message testing with university students or other focus groups?
Yes, we have done quite a bit of focus groups. I've actually informed my communications director that I won't use all of the language she uses about theories of change and all of those other things to be able to communicate the strength of the work we have in our communications plan. In particularly, we were focused on doing focus groups, qualitative focus groups and key informant interviews with individuals who are part of our racial and ethnic minority community. So our Black African American population, our African immigrants, as well as our Latinx population here in the district. And we did those in partnership with community-based organizations that serve them. One of them focuses on youth services and programs. The other is a network of health advocates that advocate for resources in our wards 7 and 8. And then we had another group that again focused on our African immigrant population. So the information that we've received from them helps to inform how we do our messaging to the Latinx community, ranging from the actual messaging itself, because many things don't translate the same. When you're talking about hesitancy, you can't just write something in English and then translate it into another language because it loses its meaning or doesn't have the same strength of message. We've also dealt with, had discussions with them about the placement of this content. Where is the place that most folks will likely go? I think similar to other jurisdictions, we will have our hands full in terms of the most effective strategies for our youth and young adults, regardless of educational status or station, because many of them look to a lot of, as Dr. Frederick mentioned, the social media resources and platforms. And so we have to be very savvy about what the credible messages in that group looks like. It was really easy for us with our senior population, our individuals with chronic conditions. I mean, here, you have people who are, Eric Holder was one of ours, the late Marion Barry's wife was one of them. So we were really able to pull many of our council members, we were really able to elevate them as early adopters of the vaccine and do videos that appeared as PSAs as well as on all of our social media content. But getting to the root of who would be best for our youth population, older people in DC think that the go-go community is the best way to go. When you have conversations with younger people, they tell you something different. Some of them validate the go-go community, but I think that it's going to be very interesting in terms of the rollout of our platform, particularly for youth and young adults.
Great, thank you.
Yeah, and on the first part of the question, Michael, I think, again, the key is having open lines of communication. Dr. Nesbitt and her team in general, I think, have done an extraordinary job of connecting, not just with Howard, but I'm the chair of the consortium of universities in the Washington region, and they've had more than one engagement with us around what we're doing. Because the other thing as well that I think can be confusing, especially with so many, I think this is a college town personally. We probably have more university students than Boston per capita, but I'll argue that some other day. But you don't want to have, universities off and running in different directions, and then you have all these different rules. So we've tried to approach it, from the same position. And you think of commencement is coming up in the spring. Again, having, some collective message around what waivers look like and why, and that applies not just to vaccinations, because even if you vaccinate everyone in DC is one of those cities that everybody is traveling to. And so we also want to make sure that we're consistent in terms of understanding what the Department of Health is trying to do, so we don't put the citizens of DC at risk. And so even as we think of bringing students back, we really swell the population significantly as well. So we have to be careful. So the lines of communication have been open, and we've tried to do it through several different mechanisms. And I would say the Department of Health has been extraordinary in terms of keeping those lines of communication open.
Great, thank you. I want to remind folks, if they have questions, feel free to put those in the Q&A. And I just wanted to ask a question of all three of you. The new American Rescue Plan has trillions in it, 1.9, and billions for public health. And one of those lines is a investment in vaccine confidence building, communication in particular. And so obviously you'll get a piece of that 1 billion in the district, and we'll see that granted to states. But I'm wondering, if you're thinking about these investments in vaccine confidence, what would be the one or two things you would really want to invest in to build vaccine confidence? And I don't know, Jillian, if you want to start from your research, and then we can go to Dr. Frederick and Dr. Nesbitt.
On the communication side, really, it's about bringing together the experiences that are going to give people, kind of telling the stories that are confidence building. So, I often say that, you can't give a nifty tagline. You can't have a great bumper sticker or a t-shirt that's going to make people trust you. It's not about messaging, right? It's about being trustworthy. So I think as we become trustworthy in this endeavor, the key is to build out the stories of this, to build success, not only in this pandemic, but broader. This is an opportunity. It's a hard opportunity. It wouldn't be one that I would choose. But now that we're facing this, I think the opportunity is really to build out vaccine confidence more broadly, and to take them the positive stories that are going on so that we can build out trust. Because right now, I feel like we're trying to build out from, there's sort of like a sea of distrust, and we have like little islands of trust. And my basic strategy that I'm advising people is like build out from those islands. But what I want to see happen is actually that to happen, and more stories about what's underneath that. So the work that colleagues are doing here, that's going to have to be showcased going forward. So that's really how I would build that out long term.
Yeah, there are two things that I would love to see us focus on. One is using the trusted messengers to build on that point. And I think HBCUs are trusted messengers. Right now, most HBCUs are closed. And I think if you have an effort through the American Rescue Plan to use their student health centers as vaccination sites, I think you have an opportunity there to really get into the communities that have been adversely impacted. And I think that that's one opportunity. The second is one that has been troubling me. I do think as a nation, and I definitely hope that we will see this in DC as the data integrity gets better. I think we had clinical trials that had tens of thousands of people. We now have millions of people vaccinated. And I think it would behoove the government to put data out about what has happened to the people who have been vaccinated. I think if we do that, it's a great opportunity. You've now gone from thousands to millions, and you say to people, these are the number of reactions we've had that have been allergic. These are the number of people who've actually gotten infected. Since these are the numbers that actually went to the hospital, these are the numbers that died or didn't die for that matter. And I think that there will be no greater message to convince those on the fence who have been saying, and we hear that all the time, I'm just waiting to see what happens. Well, let's tell them what has been happening, and let's tell them that we are seeing exactly what we saw in the clinical trials, but we're seeing it on a mass scale. And I think people just aren't seeing that. We're relying heavily right now on anecdotal evidence that is what has been happening, but I do think we need to push it out. The other reason why I think that's an important thing to do right now, this issue with the AstraZeneca vaccine, again, poorly communicated and poorly understood, could prove to be a stumbling block. The incidence of clotting is less than the incidence of clotting in the general population. So we have to be careful. We need to get the data and push that out. But when you have countries, like Spain and Germany halting that vaccine, people are not going to hear AstraZeneca. They're going to hear vaccine, and they are going to start extrapolating that to the other vaccines. So we have to get in front of that, I think, on a national front and put out the information that exists right now.
And I would add to this that, when we think about investments in communication and outreach, a lot of people's natural inclination is to go to what's your media strategy? How many ads are you going to buy? Are you going to use bus dioramas, mass transit? Are you going to be more dense in neighborhoods than others? And I think that that's fine. But the conversations that we're having with people and that we're trying to move people from hesitancy to acceptance to action actually requires you to be more connected to people. And the passive imagery that could be effective in some situations may not be our best tool in this regard. What we have set up with the referral site program and the vaccination information centers, however you would like to think of them, is really having people in some of our community-based spaces. We really want to engage our food banks. We have something here called collaboratives, which provide a host of human and social services to residents, really empowering them to be able to provide factual information about the vaccine. We give them a toolkit, helping people to navigate the system because they have relationships with folks. They see people once a week and no less than once a month in many cases. And when someone hasn't been seen for a while, they're actually curious and interested enough in knowing what's going on in that person's life. So how we think about investing in the infrastructure of those types of initiatives, I think is going to be critically important. While you'll have many who will raise their hand and say, we'll do this in kind, they're actually taking a staff member who might be a social worker or a administrative and operations person or someone who helps to do programs that may be on pause because of the pandemic. They're taking those staff and redirecting them to these efforts, and they could benefit from the financial resources of actually hiring up just to be able to do this kind of education and outreach. And I think it's critically important for us to recognize where we will be when we talk about the future. The future is the beginning of May. And often remind people when they're talking about when we start to see hesitancy. Well, if you really look at your data, you're seeing hesitancy in other groups already because we have a phased approach to vaccination. And when you tap out at only 40 to 50% of your first responders getting vaccinated, 50% of your hospital staff getting vaccinated, those populations have hesitancy too. And some of that hesitancy is driven by the people of color who work in those organizations or in those sectors. And some of it is because they were first and didn't have the same amount of information that we have now available, as Dr. Frederick has mentioned, around vaccine and vaccine safety. So I like to try to take the opportunity to shift people's thinking about we get to hesitancy once we have vaccinated 40–50% of our total population, and people are still just trickling in. It's really important to think about it in each subcategory of eligibility.
Great, thank you. I want to conclude by asking you just to share one key takeaway or one key point you want to make sure you share with this audience before we conclude. Anyone want to take a start?
I'll take a shot since I'm the only non-public health official on here. In all seriousness, I think one of the things that this pandemic has showed us is the interconnectedness of our society. And I hope that at the end of the day, that's the one thing that we all will take away. There are unsung heroes among us every day that are doing things to protect our society. And so, again, I hope that the members of your association would feel my heartfelt gratitude when I say that you guys are angels without wings. And so I'm glad that you're grounded here on Earth for some period of time and are continuing to help all of us stay safe and healthy. So please keep up the excellent work, and anything that academic institutions like Howard can do to support the work that you're doing, we stand ready to do that. So thanks again.
Great, thank you.
Yeah, I would say that, one of the key things for us is we often talk about quality improvement cycles and PDSA or PDCA cycles, et cetera. But this year has really revealed, don't let the perfect be the enemy of the good. So when you're thinking about making a shift in your approach, if that's how people get access to appointments, if that's about the location of vaccine sites, I would encourage people to not be paralyzed by having 100% of the data element questions answered. You can observe trends, you can observe patterns of concern, and begin to act on those immediately. We still, again, many of us still have 20%, 10% of our race and ethnicity data missing, but we know what the data we do have says, and that can help drive decision-making and should begin to drive decision-making much sooner than later. So data-driven approaches are extremely important. We'll continue to improve the quality of data because many people are using brand new systems they've never used before. But we also can anchor that with the qualitative information that we know and we have to be able to act quickly in the best interest of the people we serve.
Thank you.
Well, it's going to be hard to top those comments. So I'm not so sure I love becoming last here. These are great. So let me actually build on that a little bit though, and take from that and say, what I would say is that this is a hard opportunity, but it is an opportunity. And when I look at colleagues who are doing this amazing work, and I see that the opportunity to showcase some of that can actually begin to build trust that we've seen fall. So before the pandemic, we've seen distrust fall, and this is an opportunity actually to build that up. And so showcasing some of this work that the Angels Without Wings are doing, some of this, quick action and response, I think is really a chance for us to change the way people think about public health. I've been working on infectious disease outbreaks and pandemics for a long time, and until about a year ago, nobody knew what I was talking about when I said the word pandemic. Now everybody does. And so let us not let this go, right? We've all faced the challenge of public health, which is that until there's a crisis, no one's willing to do anything. Well, right now there's a crisis, and how we can leverage that going forward is really critical. And as we do so, thinking about data that gives the voice of the people, their experience and their lived experience to that is great. And I would say that, building on Dr. Frederick's comments, that we have a partnership with ASTHO to be collecting and using data in these ways to help guide communications, and hearing from members about ways that data and those efforts can be improved is always really important. And so we look forward to being able to serve you and the work that you are doing so critically in this effort. Thank you.
Great. Well, thank you to all three of you, experts and wonderful colleagues. We appreciate your time this afternoon and all that you're doing. Dr. Frederick, Dr. Steelfisher, Dr. Nesbitt, we really appreciate your contributions, and thank you again. And with that, we'll conclude our session and invite folks to visit our ASTHO website for future events. We have a couple more events in this series. And also ask that folks that participated to please fill out the evaluation if you hadn't had a chance already. The link will be available in the chat. So thank you all and have a great rest of your afternoon.